This is Jorge Fortun to the third installment of the New Retina Radio Journal Club with participation from members of the Witt-Buckle Society. Hopefully you were able to listen to the first two episodes and get a feel for what we're doing here, but basically we're reviewing the latest and greatest in journal articles in a way that makes it a little bit more digestible and consumable wherever you may be. Today, I'm happy to be joined by my three co-panelists, Basil Williams, Cynthia Qian, and Christina Weng, who you've met from our previous episodes. And I'm going to ask Basil to start us off here. Basil, today's paper is a comparison of wide-field swept source optical coherence tomography angiography with ultra-widefield color fundus photography and fluorescein angiography for the detection of lesions in diabetic retinopathy. And I'm out of breath now. That's a long title. But I'm sure that your summary of this paper is going to be a lot more succinct than my reading of the title. So Basil, just take us through this paper. What were some of the findings? And then we'll take it from there.
All right, sounds great. Thanks for having me. So this is a prospective observational study conducted at Mass Eye and Ear in the British Journal of Ophthalmology, published a little bit earlier this year. So basically, they took patients with proliferative diabetic retinopathy, non-proliferative, and diabetic patients without diabetic retinopathy. And they were all imaged with ultra-wide field color fundus photography with a 200-degree single capture imaging system. And then they also took two 15 by 9 millimeter OCT images that were combined for a montage of a 15 by 15 millimeter scan. And then they also did ultra-wide field fluorescein angiography in a select group of patients so that they could make the comparison. So this study looked at 152 eyes of 101 patients and compared ultra-wide field fundus photography to swept source OCTA, where color fundus photography was better at determining microaneurysms, whereas swept source OCTA was better at detecting ERMAs or neovascularization elsewhere and neovascularization of the disc. The combination of swept source OCTA and fundus photography was comparable when looking at wide field fluorescein angiography and looking at the diabetic retinopathy lesions. And so in conclusion, they kind of decided that the combination of wide field fundus photography with swept source OCTA was pretty similar to using wide field fluorescein angiography alone. And this may be valuable because we obviously know that fluorescein angiography can be a little bit of an invasive test where patients might have reactions to the injection. And it's particularly challenging in patients who have renal abnormality or renal dysfunction, or if there are pregnant patients, et cetera. And so by using swept source OCTA, you might be able to capture a lot of the stuff that's seen on fluorescein angiography, and combining that with wide field fundus photography gives you pretty similar results.
I'd like to open it now to the group at large. I think that this is the kind of paper that lends itself to good discussion. I'd start off just by going around, and Basil, I'll include you in this, but Cynthia and Christina, I'm interested, we all practice at academic medical centers, and but even in that setting, how many of you have access to swept source OCTA, wide field swept source OCTA? So, I see Cynthia and Christina shaking their heads right now. Basil?
I do not.
Yeah. So I think that, so we do here at Bascom, we just opened a new retina center, and the reason we were able to purchase 3 of these machines, 1 research and 2 clinical, is because we had donors, that allowed us to purchase them. But I think work like this is important because it proves the utility of this technology. And it shows us what we can achieve with it. And so I think it'll drive the production of more affordable units. But, Basil, I thought you brought up an interesting point about dye-based angiography. And I will still say that I pretty much get wide field angiography on all my patients. How about you guys? All my diabetic patients, I should say.
So at first visit, I pretty much always get fluorescein angiography on my diabetic patients.
Yeah, if they have some sort of diabetic retinopathy, of course. If they don't
Correct.
have an EDR, but Christina and Cynthia, maybe you guys, what's the value of seeing that mid-peripheral or peripheral vasculature to you?
I think first of all, we've seen this in studies already that, even under careful examination by a retina trained specialist, you can miss things out there. Subtle, flat NV, ERMA lesions, it's hard to quantify non-perfusion without that help of a fluorescein angiogram. So I think just by elucidating all the findings that are actually present, I think that's a huge help. But, leakage, obviously. So you're looking for leakage, you're looking for non-perfusion. And I think a lot of these things can be very telling in terms of altering management for a patient or for giving you an idea of potentially what their prognosis is and their visual prognosis as well.
Yeah. And I agree with Basil. So I always, for new diabetic patients who come in, I always get a baseline fluorescein. At least, I try to aim for, perhaps every 6 to 9 months after they've been, in follow-up either for injections or lasers or treatments or even just regular follow-up, I'll try to get a comparison fluorescein again just to see the progression. And I think, in the absence of having other research tools such as the swept source OCTA, the FA is still very, very telling and very helpful and reassures me and guiding me in my practice.
Yeah. I think the one interesting thing that was brought up by this is the utility of combining two imaging modalities that are non-invasive and that can be used to very accurately diagnose patients. And I think we've all changed our practice models, and I think a lot of us have gone to what we call hybrid visits, and we're really starting to realize the value of imaging modalities. And I might get ostracized or excommunicated from the retina community by saying this, but the relative lack of value of the traditional physical exam. And I think that when you're talking about technology that can further replace something that involves direct or skill like doing a dye-based angiogram, that this becomes very exciting as far as diagnosing our patients remotely, so to speak. I know that you guys don't have swept source OCTA, but since we're talking about wide field imaging, perhaps you guys can talk about how that's played a bigger and bigger role, perhaps in your practices during this pandemic. I know we're going a little bit off topic here, but I think it's interesting to talk about.
Yeah, at Baylor, at least, we've tried to really streamline those patient visits. So we want those patients in the office as little time as possible. And so one of the ways to help do that is, of course, by eliminating some of the testing that takes a longer period of time, such as a fluorescein angiogram, unless I feel like it's really going to change management. One of the great things about ultra wide field imaging is you can really, I don't want to say it's a substitute for the physical examination because I still dilate these patients and take a look, but it sure does give you the reassurance that you're catching all the findings that need to be caught. And what's wonderful about it is it only takes a few seconds to acquire. So that is a huge thing. And I will say that OCTA, there's tons of research going on. I think it's a very promising tool, and it's great that it's non-invasive. I think one of the drawbacks still is that it's not quite as quick as an OCT or an ultra wide field fundus photograph. And so if you really look at their methods and what was done here, they took separate superior and inferior 15:9 images that they had to montage. And then while the vascular layers were segmented on an automated basis for the vitreal retinal interface lab, each B scan they looked at closely and they actually did manual segmentation. There's also a lot of artifacts that are introduced in OCTA, and I can speak to this because I use that too in our office here. So it's an imperfect tool right now, but like everyone else has alluded to, we're actively studying it and we're learning more and more about it. And I do think it's going to have a tremendous value and place in our practices in the future.
Yeah.
Great. Yeah. And in my practice, as Christina said, obviously I also see pediatric patients. So as you can imagine, the ultra wide field imaging is super helpful. What used to be sometimes long exams under anesthesia or, can now be replaced by a really quick exam that the child tolerates really well, that allows us to see really far into the periphery, that, also eliminates the need for additional, timing, stress to the child, to the parent, and also the anesthesia process. And I think it's really, not only during these times, but overall really helped with the general practice and the proportion of a lot of my pediatric patients. And I think I agree also with what Christina says. A lot of these, I think, even though they're kind of in the research phase, we do need to push forward and have these, come into our practices so that they're perfected, so that the acquisition time goes down, so that, the images become even wider field. I think in this study, it was very impressive to see that color fundus photo with the swept source was almost as good as the FA, but there was, for example, one lesion that was outside the 50-degree center imaging from the swept source that was missed by that imaging, even though it was combined with color fundus that was picked up on fluorescein. So, but really, I think it's only by having these tools in our hands and having them evolve that we're going to be able to get that, 5-second acquisition time and wider field just from one picture, just like we have with ultra-wide field imaging per se.
Yeah. And I do hope it becomes more accessible, both from the standpoint that costs will go down, that the technology will get better and more user-friendly, because I can attest that, there is a lot, it's very work intensive to get these images, especially when you're talking about the montage. Currently we're not being compensated any more for this. But I agree, sometimes with this new technology, you don't know what you don't know. And so the more you study it, the more you find out. But I think certainly what's not arguable amongst this group of individuals that's discussing here is that there is a utility to wide field imaging, and that there is some utility to continuing to explore this non-dye-based technology going forward. And with those words of hope for the future, I'd like to say goodbye on behalf of my co-panelists. Thank you for joining us for this third installment of New Retina Radio Journal Club. I'd like to thank iTube, New Retina Radio, certainly support from the Vit Buckle Society, as well as, again, my co-panelists. Please remember to download this podcast wherever you download your podcasts. You can also visit itube.net to see a video version of this. And please don't forget to subscribe and rate us so that we can improve future content. And with that, thank you.